Hi. Today we're going to examine the question of normal aging, and we want to review some of the basic principles on the biology and physiology of aging that have clinical implications for both clinical assessments and for healthy longevity. I'm reminded of this poem by T.S. Eliot, With Each Patient Encounter. I've lost my sight, smell, hearing, taste, and touch. How should I use them for your closer contact? This reminds me of the neurosensory impairments that older adults have, and often our communication has to be guided by an appreciation for the fact that older adults may have hearing impairment as well as visual impairment. So the goals today are to look at aging demographics. I want to briefly look at theories on aging that are helping inform what we call gerobioscience. And we want to be able to distinguish normative aging from disease and old age. You know, it used to be that people thought that memory loss was a normal part of aging, and it wasn't really until scientists and clinicians gave that condition a name, Alzheimer's disease, that people actually understood it to be that as a disease rather than a normal process of aging. So some people say that aging is not a disease, and I think that's a good understanding of how we should view the older adult population. Well, this may seem like a simpleton question, but quite honestly, 30 years ago, people thought that aging was irreversible. Over the years, research has shown that aging actually can be stopped and possibly reversed, and so this perspective has changed considerably. So in the left column, we see the traditional view is that aging is an inevitable process of biological breakdown, that is cumulative and irreversible. And so the approach is to ameliorate aging problems with medications, pain control, and it's a very disease-oriented process. But on the right-hand column, really the question becomes that if we slow the aging process or stop it through a variety of means, which may include things like plant medicinals in combination with biologics, that by slowing the rate of aging even, that we may be able to prevent age-related diseases. Now, the converse of this is to think about something like diabetes, which is an aging accelerant. And so it would be true that a lot of the age-dependent diseases are more often seen in the diabetic population than in the non-diabetic population, so that you see both ends of the spectrum of how there may be populations of older adults that have accelerated aging and those that have a slower rate of aging. And the question is, what can we do to mitigate the rate of aging? And we'll offer you some ideas as we move along here. So some common principles. One is that there's a disconnect between your biologic age and your chronologic age. And recent research shows that dramatic situation in terms of some of the population being older than they actually think they are, and then some of the individuals in a population actually being younger than their chronologic age from a biologic perspective. The other point is that organs age at different rates, and so the most impressive example is the involution of the thymus gland, where by basically the age of 20, the thymus gland is fully involuted, and the immune system has been established as a consequence. Other organs, such as the brain, do not age at quite the same rate, obviously, and other organs, such as liver, have regenerative capacity. Certainly the brain has neuroplasticity and regenerative capacity, but at a very different level than, let's say, liver. And the other principle that we alluded to earlier was that the rate of aging can be slowed and reversed. And we'll talk a little bit about some research that supports that point of view. So here's what I was talking about in terms of the differences in a population where everybody here is the same age. They're 38 years old. And their biologic age was measured by a panel of measurements that include blood pressure, centripetal circumference, monocyte count, telomere length, and a variety of other measurements that give this composite score that represents a biologic age. And so you can see that it's a bell-shaped curve. Half the population at the age of 38 is older than 38, and half is younger. And the question is, what is it that causes this variation? You might also consider the fact that as we get older, 65 and older, let's say, the variation in our biologic age increases even more dramatically. And so that bell-shaped curve starts to flatten out or distribute it more. And the more recent conceptualization that 70 is the new 60 in terms of age might have some relevance as the population is aging and living longer and longer with each year. And it just reminds us of what kinds of things can we do as a population as well as individuals to enhance or extend that healthy lifespan. So the question here is that if you look at people that are to the right of the dotted line on this curve, what kinds of things can we prescribe for them that will move them to the left of that dotted line of 38 years old? And so some of those things are physical activity, nutrition would be two examples, and there might also be some chemotherapeutics that we can discuss as part of a research protocol that might influence that curve to the left, if you will. So take a look at these folks. Three gals here that would like you to estimate their age just for a moment. And as it turns out, somewhat surprisingly, these people look younger than their stated age. This is an important concept clinically, that when you do see a patient, when you see them to be younger than their stated age or perhaps older than their stated age, research has shown that that actually is a pretty good barometer or metric for their biologic age. So I highly encourage clinical encounters to include a statement as to whether the patient on physical exam looks older or younger than their stated age. So we've established that patterns of aging varies from person to person, and we want to talk about the genetic component as well as the environmental component. Think for a moment how much genetics play a role in healthy longevity. When I ask this question, many people respond by saying, 50%, 80% of your healthy longevity is associated to your genes. Research actually shows just the opposite, that the genetic component to your healthy lifespan perhaps is only 10 to 25% contribution. and that most of the healthy lifespan is due to environmental considerations. So these include exposure to toxins, accumulated toxicity, as well as our habits that include physical activity, proper nutrition, and as we'll discuss, individuals, for example, in the Adventist study who were vegetarian typically lived 6 to 10 years longer than other people in the study who were omnivores. So choices that we make over our lifespan may influence our longevity. Here's a pictorial or a cartoon display of what we're trying to accomplish. So at the left side here is early life, and over time we can see that there's a progression of the population or an individual towards lower functionality and eventually the endpoint of death. As geriatric focused individuals, we want to keep everybody above this dotted line. We want to maintain as much functionality as possible, and to do so through mostly prevention measures. Some of these treatment measures may, over time, as we'll see, creep up into this higher category as a chemoprophylaxis for, let's say, senescent cell removal from your tissue. So when we look at the definition of aging, I think it would be fair to say that it is the sum of all changes that occur with the passage of time and leads, importantly, to functional impairment. So if anybody ever asks you what the difference is between geriatrics and usual health care, that highlighted functional impairment is the key answer. So over the last decade, we've had unprecedented growth in the aging demographics. Some people call this the silver tsunami. Here are some population graphs that you can see starting from the 60s to the 1990s through 2020. This is called the rectilinearization of the curve. And you can see the baby boomers there in pink marching right on up and contributing now up to 18%, soon to be 20% of the overall population in the United States. So here's a distribution map by county that shows where older folks are located, up to 33% in some of these dark and blue areas. And just to look at the Great Plains, you can see both on the Canadian border and through the central parts, the rural parts of the Great Plains, actually consistently throughout the country, is where the oldest old reside. Not surprisingly, these are the individuals that have the least resources to manage functional impairments as they get older, and so it poses a really big question in terms of what can be done to help these individuals age in place. So overall, we understand aging and life expectancy to increase over time, and this is a somewhat older graph and projection, but it illustrates the point that both women and men have a higher life expectancy. So individuals, for example, at the age of 85 will have 5 to 6 more years of life expectancy. I want to make an important point here, is that this is absolute life expectancy, until the time of death. This does not talk about functional life expectancy. And so usually functional life expectancy goes hand in hand with absolute life expectancy, but there's a difference of about 2 to 3 years between the two. So in other words, if your absolute life expectancy is 91, you will spend 2 years prior to your death in some form of functional disability or impairment. So this is the window that we're concerned about, in particular in geriatrics, as to how to deal with those 2 to 3 years of final life expectancy that are associated with some sort of functional impairment, and functional impairment being defined by measurements such as loss of an activity of daily living, such as grooming or needing assistance with bathing, for example, but it also might be more subtle, so as the inability to go grocery shopping, or perhaps problems with finances or paying bills. I'd like to just briefly discuss theories on aging. And you can see a list here. All of them have credibility. No one theory accounts for everything. I'm reminded of the immunologic theory of aging put forth by Dr. Roy Walford, a pathologist from UCLA. Once I was at a meeting with him, and he was a big proponent of caloric restriction for enhancing healthy longevity. And so he was quite a thin man, ate very little. And when we were at the lunch table, I was coming back from a run, and I was quite hungry, and I was whipping through a couple of tacos, and Dr. Wolford was wagging his finger at me. And I said, "Dr. Wolford, are you pointing your finger at me?" And he says, "Yes." He goes, "If you eat like that," he says, "you won't live very long." And I said, "Good gracious." I said, "I appreciate the thought." He says, "However, I'm left-handed, and my mother had me as a child when she was quite old in life, and I think I'm a product of what we call the Lansing effect, where individuals that are born late in life have shorter lifespans," at which Dr. Wolford recognized the risk for me and said, "Well, then go have another taco." Apparently he felt that there was no hope for me for a long life. Some of the other theories that we want to talk about that seem to have some importance is the mitochondrial theory. So researchers have found that mitochondria DNA mutations occur at a much faster rate than nuclear mutations, thus posing the mitochondria to be age-related dysfunction. Certainly, there's a lot of evidence that shows that these mitochondria do not produce energy as much. And in fact, there was an article somewhat recently that showed that one-carbon metabolism is defective in T cells from aged donors, and that defect can be compensated for or reversed by glycine and formate supplementation. So that needs to be investigated clinically, obviously, but I think it offers some possible insights for clinically translating some observations that have been made in the biology of aging. One of the other points on the mitochondrial theory is that reactive oxygen species, ROS, oxidant injury also increase, and as a consequence that there's an increase in accumulated damage, particularly with proteins that start to cross-link or are damaged and become dysfunctional. This leads to an increased susceptibility to cell death and programmed cell death called apoptosis. Telomere theory got a lot of attention about a decade ago or so. These are the end plates of the telomeres that shorten, and they're seen when cells sequentially divide in a cell culture. They start to lose their replication capacity. They become inert, and if you measure these telomeres at the tips, they become very, very short. Part of the reason is that the enzyme that puts those endpoints and maintains them, the telomerase, its activity decreases with increasing age. Now, it turns out that certain conditions, disease, can impact telomere length. So, for example, HIV-infected individuals tend to have shortened telomeres compared to age-matched controls. People who are sedentary or obese have shorter telomeres than those who are active. Now, the good news is that if you increase your physical activity, you can actually put a little bit more length into your telomeres. So it is a reversible process. And one of the reasons that we would want to advocate increased physical activity and to reduce obesity for impacting biologic aging. The other thought and theories on aging is that transposons get disrupted, leading to genomic instability. There's also some thoughts that the methylation of protein around the DNA and the DNA itself becomes altered. Well, this has been true in most cases in studies. It's not clear that those changes in the DNA actually affect relevant genes for everyday metabolism and functionality. That a lot of these changes occur in what we call inert or non-transcriptionally active DNA. A recent theory proposed by Dr. Horowitz is that there's an epigenetic clock in that basically that there is DNA methylation that increases with increasing time, and that you can predict somebody's age based upon this methylation clock. And so this has gained a lot of attention. But again, this relates to this whole question of what impact does it have on transcriptomes and transcriptional activity that would be important for the aging process, and that has not yet been established. Another important theory is called era catastrophe. This is where there are damages to protein that include cross-linkage. So diabetes, for example, is actually is a good example of what are called age-generated end products, or another name for the person who discovered them, Amadori products. And these are covalent cross-linkages between glucose and the and peptides, and so you get this cross-linking events that cause protein aggregates, and in some cases people believe that it causes what we call proteotoxicity. So these aggregates of protein actually become toxic to the cells. An additional theory we had mentioned is immunosenescence. Typically the T cell, memory cells in particular, accumulate, as you would expect with aging, and the naive T cell subset starts to decline. Those naive T cells are less able to be activated under circumstances of infections. Sometimes they get dysregulated and cause autoimmune type reactions. Most of the aging immune system is within the T cell branch, although more recently research has shown that there are some defects in the B cell progenitor cells, and that macrophages and monocytes are also defective, and there is new emerging evidence that these monocytes and neutrophils migrate to inflamed tissue and send out inflammatory signals that are sustained. And so while the overall impression is that the immune system is slow to get activated in older adults, that once it is activated, it may produce a cytokine storm that is perhaps not reversible. and more recently with the pandemic with COVID, the cytokine storm is one of the indicators of bad outcomes, and the older adults are the ones that are succumbing to the pneumonitis more so than younger individuals, and one of the mechanisms may be the cytokine storm. So the aging process can be viewed as a functional impairment over time. This is one of the goals that we're trying to achieve, is to keep everybody 100% highly functional. And you can see that in an average population, that functionality over that population declines as they reach their life expectancy. Some people, such as diabetics, maybe alcoholics, maybe substance abusers, will have an accelerated loss of function. Conversely, people who are successful agers, if you will have a slower onset and amount of functional disability. And so basically we want to move the curve here from red to blue. I mean, that's one of our goals. And certainly through behavioral and lifestyle interventions, try to move this green curve over to the red curve. Mentioned that organs age at different rates, and so their manifestations as we see the older adult are as displayed here. We know that kidney and heart function are the most susceptible to age-related processes. Other things such as physiologic changes in body temperature really don't occur so much, and so if you see somebody with a lower basal body temperature, let's say 96 Fahrenheit, you might want to consider that in the context of hypothyroidism or other reasons for a lower resting body temperature, as opposed to blaming it on age per se. So here we'd like to go from organ to organ tour of what aging does to the organs. And so with the aging eye, we know that there's increased iris rigidity. The pupil may be sluggish in dilating and accommodating, and so this actually becomes a problem with light to dark adaptation, where people, after they see a bright light in the older adult population, may have temporary blindness for a longer period of time than the younger population. Of course, there's cataracts that occur with increasing age, sometimes accelerated by certain occupations such as sailors and fishermen who have the reflected UV light off the water that accelerates cataract formation. There's syneresis, which occurs because of the vitreous contracts, and basically those are floaters that we talk about, little spots that we see floating across the eye. And you'll see less of a foveal, that so-called red light reflex as people get older. with glaucoma. You can see on the retinal exam the increased cup to disc ratio and the so-called nasalization of blood vessels. And you can see here that there's visual impairment of basically peripheral vision is reduced substantially. There's also senile macular degeneration, and there's the so-called wet exudative senile macular degeneration versus the dry, which is more prevalent. And you can see, again, central vision becomes blurred with people with senile macular degeneration. There are auditory changes with age, and so you can see that with increasing age that there at least up to half of the population has hearing impairment. This occurs insidiously, and so people don't always recognize that they're having hearing loss, and sometimes they'll blame their spouse for not speaking clearly enough or loudly enough, mumbling. Those may all be indicators that the individual is having reduced hearing. The prototypical audiometrogram is shown here on the left. So this represents presbycusis, which is the loss of hearing at high frequencies. And so you can see in the upper part of the graph, this x-axis here is that 4,000 to 8,000 hertz requires very, very loud conveyance of those frequencies for people to hear them. Sometimes the hearing impairment is compounded by cerumen impaction, and so I think it's absolutely mandatory with each clinical encounter that the older adult have their ears examined, both in terms of hearing test as well as for cerumen impaction. So as mentioned, presbycusis is the result of bilateral high-frequency hearing loss. As mentioned, it's insidious, and it's recognized when the hearing acuity dips below 8,000 hertz. Sometimes it is associated with ringing in the ears, tinnitus, and there is a gender difference where men experience more hearing loss than women. And you should also consider hypothyroidism as one of the reasons why hearing loss might occur in the older adult population. There are consequences for presbycusis. As mentioned earlier, there's deterioration in communication. Sometimes people feel more isolated. Family members and friends may consider the person senile as a result of hearing loss. All this leading to increased depressive symptoms, sometimes even paranoia. They're talking about me. And then further functional impairment related to this withdrawal from social activity. In terms of the aging mouth, I want to highly emphasize, as seen in the slide, dry mouth can be accompanied with dry eyes, but the impact of this is not so much with aging, but rather with medications that reduce salivary flow. Typically, these are anticholinergic medications, which are generally a no-no in the older adult population. So a prototypical medication that's commonly used is Benadryl, diphenhydramine. This medication is highly drying and anticholinergic and can cause confusional states in older adults, as well as this general phenomenon of drying the mucosal membranes. I want to briefly touch upon neurologic and cognitive changes with aging, covering the central nervous system through the peripheral nervous system and the autonomic nervous system. So cerebral blood perfusion generally declines with increasing age. We haven't quite put together the functional consequence of that. So low perfusion does not always necessarily mean less brain function, but suffice it to say that there are studies that are looking at both function of the brain as well as brain volume, particularly hippocampal volume, as a proxy measure for Alzheimer's dementia. And so progressive loss of hippocampal volume has been linked to Alzheimer's disease. And interestingly, some research shows that individuals on a Mediterranean diet, particularly those supplemented with fish, have a lower rate of hippocampal shrinkage over a 5-year period than when compared to people that are on a more diverse omnivore type diet. So there's some subtle changes with memory and aging. These are typically called tip of the tongue word searches. People try and think of a particular word and just can't recall it. This can be seen with aging, but for the most part, the acquisition of memory is a little bit slower with aging, but it is not defective. In terms of reflex, this is a study that was done by John Disterhoff many years ago, and it shows basically a Pavlovian conditioned response where he took a eye blink, a puff of air in the eye, and coupled it with a ding sound, and eventually got rid of the puff, and people still blinked with the sound over a period of time. But as you can see, that blinking started to extinguish after so many repetitions. And so one of the rate of extinction was at a certain rate for younger people and was fairly quick, whereas it took longer for the older people to extinguish that reflex. There was an interesting study from Finland where they compared older adults with young adults, trying to memorize their mini golf score, so a little bit of physical activity with memorization. And so the young and old had equal abilities to remember their scores without auditory distraction, but once there was some loud music interjected, I think they were playing the Rolling Stones, and it turns out that the older people had less memory retention as a result of that distraction. This is some research that I collaborated on, and basically what it shows that in the right graph here, the loss of sympathetic tone over time with elderly. This is a cross-sectional study, but you can see there's a steady decline in the sympathetic tone. Whereas the parasympathetic tone in a cross-sectional study appears to have a U-shaped curve, where folks that are older, 85 and older, tend to have a parasympathetic footprint, if you will, similar to those that are in their 40s and 50s. The relevance of this is not clear. It's not clear really whether these individuals with high parasympathetic tone started off with high parasympathetic tone when they were younger, or whether they just sustained it or actually improved it through different measures. You might say, well, what kind of measures could they take? Those would be physical activity, mindfulness, and so certainly meditation, for example, improves parasympathetic tone. So the other observation that was implied by those graphs is that heart rate variability decreases with age. And if it goes down to, so those are beat-to-beat variations. There are several studies that show that with more than one standard deviation compared to your age-matched control, that low heart rate variability is actually a predictor of mortality. So you have a twofold mortality rate with low heart rate variability. So again, things that can enhance heart rate variability are those things that help slow the heart rate down overall. So a slower heart rate has more variation. Things like physical activity will slow the heart rate down. So that seems to have the most impressive impact on trying to reduce heart rate, trying to improve heart rate variability. We know that the environment has an impact on heart rate variability, and this is an example from a study that showed that when ambient particulate matter and air pollution, if you will, accumulates, that the heart rate variability in older adults declines dramatically. And that may account for one of the reasons why highly polluted areas, heat stroke, which causes a lot more, heat waves, cause a lot more ambient particulate matter, maybe part of the reason or the mechanism by which older adults succumb during heat waves. I want to talk a little bit about the heart and aging. So it turns out that as we get older, a third to a half of the population has systolic blood pressure. So certainly all 65-year-olds will have, a third of them will have high blood pressure. By the time they reach 80, if they do reach 80, 70% of them will have systolic hypertension. Part of the aging heart is that diastolic relaxation declines, and so the heart is not able to accept as much blood as younger. And so in some cases that problem with diastolic relaxation results in diastolic heart failure. There's also a decline in the refractory period by which the heart recovers and basically creates the squeeze to push the blood out. Associated with the aging heart is the aging respiratory system. There's this concept of senile emphysema where the alveoli enlarge. They're not destroyed, they just become more bulbous. And as a result, there's less surface tension and less recoil. Interestingly, there is some studies that show that there's an increased migration of macrophages. Part of this may be due to the accumulation of what we call the senescent cell phenotype. These are large fibroblasts that reside in tissue. They no longer have replicative potential, but they tend to exude inflammatory signals, thereby potentially increasing and recruiting more macrophages into the system. And that may be one of the theories behind the so-called cytokine storm that occurs with aging. Here's a table of different pulmonary changes. Just want to bring your attention to the FEV1, forced expiratory volume in 1 second, declines with age. And one of the other points that I want to make are the VQ inequalities, so that there's lower ventilation in the lower half of the lungs, and for that reason that we want people as they get older to be sitting up rather than lying down for optimal gas exchange. So here's an example of the FEV1 declining with age. So you can see, interestingly, that there are some old people that look like young and some young people that look like old. And so there's, again, variation in lung function as you look at a population from age group to age group, here from 25 years old to 75. With these pulmonary changes with age, the older adult, as you can see here, increasing age up to 80, that the average pulse ox declines, and so they become closer and closer to a hypoxemic state. So the clinical implications are that you get potential atelectasis that promotes hypoxia as well as pneumonia, so that's why deep breathing exercises are important. The alveolar mismatch with the blood is exaggerated in the supine position. So we therefore want to try to promote upright positioning and deep breathing exercises. Here's a study where in Britain, this is like a 2008 study published in the British Medical Journal, that showed that Mr. Smoker, if you're the age of 50, you have the lungs of a 75-year-old, and by stopping smoking, you can delay this course of lung deterioration. During the study, it was found that by showing middle-aged smokers their age-equivalent lung function, that 40% of them decided to stop smoking, as opposed to the traditional methodology of the physician or provider wagging their finger at them and say, "You, sir, must stop smoking," which only accomplishes about a 10% cessation rate. So this is one of the cases where ageism is used beneficially to change smoking habits. All right, so I just want to keep emphasizing that the supine position exaggerates decreases in PO2 and hypoxemia, so we get I guess a green star as opposed to a gold star for keeping our older adults up and moving around. Just also mention that in terms of lung aging, that there's a steady increase in cancer with age, obviously compounded by secondary smoke and primary smoking. So moving on to the gut with aging, we mentioned that dry mouth is a problem in quite a few older adults. This can lead to exaggerated problems with dentition, gingival recess, tenderness. And if somebody's starting to lose weight in the older adult population, first thing to do is look at the dentition, look for pain, particularly in older adults with cognitive impairment who may not be able to express problems with eating. So 10% of all of us actually have some form of silent aspiration, but because of the reduced oral to pharyngeal phase of pushing the bolus into the esophagus, that silent aspiration can increase up to a third of the population who are 90 and older. So you can see, as a consequence of age, that by the time you're 100, you're 100% chance of aspirating, and that all comes from this dyskinesia that occurs in the oral pharynx. Some of the key features that we need to think about in normative aging with the gut is that there are reduced contractions, less peristalsis, decreased acid clearance, which predisposes people to gastritis, particularly with the NSAIDs. But one of the big points I want to make is the reduced antral volume. So this leads to early satiation, and clinically and practically speaking, it has some implications, because if, for instance, you provide dietary liquid protein supplementation with each meal, that high protein load is going to cause early satiation, and people, older adults that is, will not consume a full, regular meal. And so as a consequence, we often in geriatrics encourage people to take protein liquid supplementation in between meals rather than with their meal. Already mentioned about the issue with acid clearance. There's certainly normal acid secretion with age. So one of the things that we notice with the aging gut is that there's an increase in reflux. Part of that may be related to the 30% of the aging population that's obese, as well as for other reasons. But one of the implications for this is that there's an awful lot of proton pump inhibitor prescription, as well as H2 blocker prescriptions. More recently, Zantac was taken off of the market because of contaminants that are highly carcinogenic. And there's a movement afoot to reduce proton pump inhibitor use long-term in the older adult population for two reasons. One is that proton pump inhibitors predispose older adults to accelerated osteoporosis. And secondly, it predisposes them to C. diff colitis if they are on antibiotics. So in terms of other issues with intestinal aging, there's some minor changes in the small bowel. So there might be a little higher population with lactose intolerance. And so if somebody that comes in to the clinic and talks about loose bowels, diarrhea, that you might consider lactase deficiency as your first line of thinking. There's also a higher incidence of bacterial overgrowth leading to decreased B12 absorption, as well as folate. And the folate, a recent article showed that diabetics in particular are most susceptible to folate deficiency. I want to just emphasize the dreaded fecal impaction. There's a lot of reasons for this occurring with age, but in your review of systems, it's so important to find out when the last bowel movement occurred. And if somebody tells you 2 to 3 days ago, that could be an issue, particularly if they have a confusional state, and if they in that confusional state can report problems with their bowels, because in one study up to 40% of delirium or acute confusional state in older adults was attributed to either fecal impaction or obstipation. So musculoskeletal changes with age, need to think about who are you comparing it to. Are these unconditioned versus those that regularly exercise? But suffice it to say that there is a steady 1% loss of lean muscle mass per year after the age of 65. What we see here are age graphs going up to 100, and you can see the steady decline in both arm strength and grip strength. We actually recently published an article with Dr. McGrath that looked at asymmetry of grip strength as a proxy measure for functional disability in the older adults. But again, because of the steady march of muscle mass loss with aging, it is so important to prescribe resistance training in the older adult. And no matter what the age is, there was a Dr. Fattori study many years ago that showed that even 90-year-olds can benefit from resistance training minimally twice weekly for 30 minutes. So the clinical implications of the aging muscle is that we get this concept of sarcopenia or dynopenia, where you get both muscle mass loss as well as overall weakness of the remaining muscle. And so as a consequence of that, a lot of people are unable to do just very small minor lifting, and as a consequence they have problems with their daily tasks. And so when you say somebody has problems transferring from the bathtub or shower back to the bedroom, that's in part because of this loss of muscle mass. And just be mindful of the fact that hospitalization is the biggest risk factor for loss of muscle mass. So there's actually an epidemic of sedentariness in the older adult population that is hospitalized. So here's an example, where physical activity prevents functional decline in older women. So exercise improves active life expectancy. And remember, active life expectancy is that period of time with preserved functional status. In terms of skin and integument, I think some of this might be self-evident in terms of epidermal thinning. I just want to bring attention to the low vitamin D levels, because as people get older, they become more homebound, less likely to be outside, and as a consequence, they get low vitamin D levels. All right, so here's 6 different pictures for a common condition in older adults, which is herpes zoster. So I want you to take a look and see which of these pictures you think most represents the grape-like clusters of shingles. Okay, so if you had picked item 4, the slide that is most representative of zoster, you can see that there's little grape-like maculopapules with an erythematous base, which is different than herpes, or impetigo, which is more confluent, as opposed to insect bites, which are spaced in somewhat of a random fashion, but not in a cluster of grapes, if you will. So just to remind us all that zoster increases with increasing age, and one of the interventions is to have the Shingrix vaccination for older adults. I often tell my patient population that at least 33% of shingles occurs on the face, and of that, 50% is associated with eye involvement, and so you'll have both reduced vision, if not the worst and extreme case of total loss of vision. So vaccination, I think, needs to be emphasized for those that are reluctant to do so. Just want to talk a little bit about nutrition and longevity. So I had mentioned this Adventist study, and it just really has impressed me that the extra years of life expectancy gained by a vegetarian forward diet is quite dramatic. Those that have vegetarian with milk and eggs get intermediate benefit. But this really, I thought, drove home the concept of you are what you eat, and that along with this improvement, there is increased functionality in the older adult population. It may not be based on this study. It may not come as a surprise that Loma Linda, which has a high concentration of practicing Adventists, that they have a exceptionally high longevity, and so they're considered a longevity zone in the world, along with Okinawa, Costa Rica, and an island in Italy called Sardinia. So, excuse me, it turns out that telomere length can be altered by aging and inactivity. So the good news is that by becoming more active, that the telomere length can be rejuvenated, and physical activity is an important intervention. Turns out that most of the studies are showing that more is better. So a recent study demonstrated that 8,000 steps per day is associated with an overall reduced mortality by 50% in people that accomplish 8,000 steps a day or more. There's other studies that reducing cardiovascular risk factors are improved dramatically with longer duration of physical activity and higher intensity. So again, more is better, such that you get 10 to 20% reduced cardiovascular risk with moderate activity, but if you go to 90 minutes with high intensity, you get up to a 40% decreased mortality risk. So turns out that our current odds of living to 100 are about 1 in 4,000. We might be able to influence that royal flush goal by improving our diet and physical activity. But I just want to also say that this ratio is going to change. So children that are born currently will have a 1 in 100 chance of living to 100. So we really do need to prepare ourselves, our healthcare system, for dealing with the fastest aging group of all, which is the 100-year-old and older population. So just to summarize, we talked today about the demographics that show a population explosion in older adults. We looked at what we consider normative aging and how that might help us clinically. We also know that not everybody at the same age looks alike from an age lens, and so we need to address their function rather than their age as we make clinical decisions. And one of our goals in clinically and through health promotion is to preserve, if not extend, functional longevity. So I'd like to wrap up this presentation by saying aging, if it's not your issue, it certainly will be. Thank you.